Be highlighting the clinical features and diagnosis of pulmonary sarcoidosis and to tell you how it presents in India. The learning objectives are to understand the variation in presentation of sarcoidosis in the Indian population, to recognize the protein radiological manifestation of this disease, and to learn how to distinguish sarcoidosis in the midst of tuberculosis that we are surrounded with. I start with a case presentation. We had a 44-year-old male who was never a smoker, presented with gradually progressive dyspnea for 6 years. He had dry cough for 5 years. He did not seek medical aid because these symptoms were not so troublesome. But for the last 2 months, he had right-sided chest pain. His history was not significant, and the general physical examination was unremarkable. On auscultation, we found bilateral vesicular breath sounds with bibasilar fine and inspiratory crepitations. This was the chest radiograph and presentation. We had a right paratracheal shadow and bilateral lymphadenopathy also. Fine reticular nodular shadows in both the lung fields, and this would, in my opinion, be suggestive of the 1, 2, 3 sign or the Garland sign. The HRCT thorax, which is normally very helpful in these patients, showed the mediastinal window revealed a non-necrotic, non-compressive lymph nodes, right paratracheal in the aortopulmonary lymph nodes. The lung window showed peribronchial beading, nodules in the subpleural distribution, and there was a distinct alveolar pattern on the right lung fields. The complete pulmonary function test was reported as normal, but if you have a look at the spirometry, it shows the inward curve over here, and there is lower limits of normal. So there was some degree of airway obstruction, but the lung volumes and diffusions were within normal limits. But when we come to the functional status assessment, the 6-minute walk test revealed that the patient could walk only 40 meters. And the test had to be stopped after 1 minute, and the desaturation occurred from 95% to 88%. The investigations which are a normal protocol in a patient who we think that is suffering from sarcoidosis, we did a Mantoux test which was not positive. Serum ACE was elevated. Serum calcium was within normal limits. Vitamin D levels were was reduced. But the LFT, KFT were within normal limits, as also was the blood sugar. The 2D echo, which is also a part of the protocol, and USG abdomen was within normal limits. Then after the bronchoscopy, actually, once we had the diagnosis confirmed, we had 2 referrals to make, ophthalmological and skin evaluation, both were within normal limits. The patient was subjected to a fiber optic bronchoscopy, and we visualized multiple endobronchial granulomas throughout both the bronchial trees. There was widening of the secondary carina of the right upper lobes, and you can see the whitish granulomas budding out of the bronchial tree. This was the endobronchial and transbronchial biopsies. It shows multiple non-case eating granulomas. There was a focal rim of lymphoid cells. The point you can see it is pointed out. There's an arrow marked over there to show in the lower lung fields as well as the high powered fields. There's non-case eating epithelioid cell granulomas with concentric calcification. The diagnosis was established as pulmonary sarcoidosis, and the diagnosis was based on the chest radiograph, the paratracheal and bilateral hilar lymphadenopathy. As I mentioned to you, there was 1, 2, 3 sign. The HRCT thorax revealed a non-necrotic mediastinal adenopathy. There was peribronchial beading and subpleural nodules, and there was alveolar shadows in the right lung fields. So the serum ACE levels were elevated, and the 6-minute walk test and the patient desaturated in 1 minute's time. The FOB visualized endobronchial granulomas, and the biopsies confirmed the diagnosis with non-case eating epithelioid cell granuloma. Sarcoidosis is a complex disease. It's a chronic disease. It occurs globally, seen in both sexes, all age groups, and all races. It is a multi-system in disorders. It's primarily, 90% of the subjects, the lung is affected. That is why it's primarily in the domain of the pulmonologist, but there is no part of the body which cannot be affected by sarcoidosis. Granuloma formation is the histologic hallmark of sarcoidosis. The question is, what instigates granuloma formation? Is it an infectious disease? Is it some kind of a cell wall division mycobacteria or some other mycobacteria, environmental mycobacteria? Is it a propionibacter? Is it a pine? These are the questions that we still need to answer. But the fact remains that granuloma formation drives the clinical picture of the disease. It varies in different individuals and can vary also from organ to organ. The manifestations of sarcoidosis depends very much upon ethnicity, duration of illness, site and extent of organ involvement, and activity of the granulomatous process. This marked variation in disease presentation and severity among different ethnic and racial groups. The presentation of sarcoidosis in India but when the picture comes to African Americans, it's totally different. It's 10 to 17 times more common. It's a more severe disease. It is chronic diffuse lung disease, the chronic fibrotic relapsing type. There's dyspnea, lymphadenopathy, skin manifestations, and extrathoracic manifestation like chronic uveitis and very skin lesions like lupus pernio. This is less amenable to treatment, but for some reasons it is only in African Americans, that is Africans who have settled down in America. The severity is not there in Africans who are in Africa. So the reasons for this is not known. In India, almost all the reported cases suggest that the presentation of sarcoidosis is akin to that of African Americans. Indians also have a chronic fibrosing relapsing type of disease that is less amenable to treatment. We have most of our patients are in the 5th decade, about 10 years older than patients who are in the West. Children and elderly are also affected in India, but in the West it is females who are more affected, but in India the data shows that males are more affected than females in India. Now, this is one of the hallmarks of sarcoidosis in India. Our patients have a lot of constitutional symptoms: fever, weight loss, loss of appetite, and fatigue. And because of these constitutional symptoms, which is very akin to tuberculosis, they are often diagnosed as tuberculosis, especially when you see the clinical picture also, the radiological picture, that is. You can see that dyspnea and cough were the predominant, much more in our patients. We also have a lot of hemoptysis. Now, this was a sign that was brought out by Dr. Samir Gupta. Crepitations were more common in Indians than in the patients from the West. Airway reactivity, we do not have any data available from India. But one very important sign that Dr. Samir Gupta pointed out was that physical signs are usually far and generally do not match the extensive radiological picture. So there is a clinical radiological dissociation. Now, when the patient comes in, he is sitting perfectly okay, but when you have a look at his X-ray, it's very alarming. This is one of the first pointers towards the diagnosis of sarcoidosis. Although not very pathognomic, many radiological features are highly suggestive of sarcoidosis, and especially when they occur concurrently. Process carrying stage sarcoidosis in 5 stages, stage 0 to 4. These are actually not stages, these are not phases, as they do not pass from one stage to another, but these are types of sarcoidosis. We may just clarify that. In stage 0, there is no demonstrable abnormality. In stage 1, there is only highly administered lymphadenopathy, but there is no pulmonary abnormality. In stage 2, there is highly administered lymph node enlargement, usually associated with pulmonary abnormalities. In stage 3, there is no highly adenopathy, but diffuse pulmonary disease is only present. And in stage 4 is the burnt out disease, is pulmonary fibrosis. This is stage 1 over here, bilateral hyaluronopathy with normal lung parenchyma. In stage 2, you can see the hyaluronopathy with abnormal lung parenchyma. In stage 3, you see abnormal lung parenchyma where there is no lymphadenopathy, and this is permanent lung fibrosis in stage 4. In India, the most common staging is stage 2. It occurs in up to 79% of the patients, and stage 0 is hardly recorded over there, but stage 1 can occur in up to 44.8% of the patients. Now, the chest radiograph is abnormal in about 90 to 95% of patients with sarcoidosis. Common abnormalities encounters are lymph node enlargement and parenchymal involvement in up to 50% of subjects. Other features that can be seen are calcification, infiltrates, micronodular, micronodular shadows, and fibrotic changes. In about 20% of the subjects, there is atypical radiological findings, and CT is very useful in recording atypical radiological. The computed tomography is very helpful as an imaging reference for when you do it as an initial workup. The indications are atypical clinical or radiological findings, normal chest radiography but clinical suspicions, the detection of pulmonary complications, and it improves diagnostic yield by bronchoscopy. In India, most of our patients, once we think it is sarcoidosis, undergo computed tomography as a routine. If you just see the clinical data, the diagnosis can be established in only up to 42% of the patients. If you combine clinical and radiographic findings, it can go up to 76% of patients. But when you add HRCT findings to that, it can go up to 80% of the subjects. CT helps to obtain biopsy and cytological material. Positive association, abnormalities and biopsy. It guides EVIS TBNA, which I will tell you a little bit later. CT guided transthoracic needle biopsy of the nodules can also be done. The CT features hallmark is, of course, as I mentioned earlier, bilateral hilar adenopathy with micronodular pattern. Other patterns are micronodular opacities with, along the perilymphatic distribution, which is also known as beading of sign, nodular and alveolar opacities, and 3 very rare signs: sarcoid galaxy sign, sarcoid cluster signs, and reversed halo signs, which have been described more recently. The other features are linear opacity, ground glass opacification, scarring and fibrosis, airway involvement, pleural involvement, and other rare signs. The nodes that are commonly involved are hilar paratracheal and tracheobronchial. The commonest presentation is bilateral symmetrical hilar lymphadenopathy. Sarcoidosis is basically a very bilateral symmetrical disease, but not that the exceptions always prove the rule. You can always get atypical presentations also, but if you think of sarcoidosis, it's always symmetrical disease. And this is the symmetrical disease, a 30-year-old man with Judge's wig appearance. You can see the 2 huge lymphadenopathies, which looks like the wigs that the English judges wear. There is fine reticulation in both the lung fields. This is bilateral asymmetrical hilar lymphadenopathy, which I was telling you about, a 50-year-old male with bilateral asymmetrical hilar lymphadenopathy with lobulated border on the right side. Bilateral reticular opacities are also visible. So, paratracheal adenopathy is usually associated with hilar adenopathy in 71% of the patients, but it's always the right paratracheal which is seen. The left paratracheal adenopathy is not seen on chest X-ray because it is located more posteriorly, is smaller in size and fewer in number. This is obscured by the aorta and the big vessels. Now, this is the classical presentation as I showed you in the X-ray in the patient I had presented. This is the 1, 2, 3 sign, or the Garland sign, or the Pawnbreaker's sign. The 1, 2, 3 sign is first to the right paratracheal adenopathy, followed by bilateral hilar adenopathy. Now, Garland was the first to recognize it. Professor Garland had a book with Hinshaw. So, this book was known as Hinshaw-Murray book. It is also known as the pawnbroker's sign because this is a very famous sign. There was 3 balls hanging, 1 on top and 2 lower of a very famous Italian family in the 18th century, which were famous throughout Europe for as pawnbrokers. So, this is also known as the pawnbroker sign. In India, Dr. Samir Gupta had said that there's unilateral hilar lymphadenopathy can be seen in up to 43% of the patients. This is a unilateral hilar lymphadenopathy in a 42-year-old man with sarcoidosis, a left hilar lymph nodes and a consolidation in the right hilar upper and mid zones mistaken for tuberculosis. Now, there is a regression of lymphadenopathy and progression of pulmonary lesions can also be seen. You can see on the left panel over there bilateral hilar adenopathy with micronodular shadows, but after treatment for 2 years, there is a regression of hilar lymph nodes with calcification and honeycombing. Now, calcification of hilar lymph nodes can be seen in up to 20% of the subjects. Usually, it is a late manifestation, probably indicative of a burnt out hyalinized lymph nodes, reported to be associated with advanced disease and steroid therapy. Axial calcification, which is more commonly seen in silicosis, is rarely seen in sarcoidosis. Diminution of the size of lymph node, or at least cessation of growth, has commonly been observed with the onset of parenchymal disease. Well, we now come to the parenchymal involvement, often symmetrical bilaterally. As I mentioned, it's a very bilateral disease, except in rare circumstances. Preferentially involves the central regions, posterior and apical segments of the upper lobe, especially in the fibrotic stage. Unilateral disease is a distinct rarity. Other parenchymal lesions are parenchymal nodules, which are very prominent in some patients, that can sometimes be the only sign visible in HRCT. Linear radicular shadows, nodular radicular shadows, alveolar acina pattern, which I will show you. Cavitation can occur in up to 6% of the subjects. Fibrosis, atelectasis, bronchiectasis, cyst, bullae and honeycombing can be seen in advanced disease. Parenchymal nodule is a more frequent radiological observation caused by accumulation of many granulomas, may be large and dense, may simulate a metastatic neoplasm, and rarely a miliary pattern can also be seen. Commonly in combination with a reticular pattern, infiltration varies from purely reticular to purely nodular. This is a 52-year-old lady with parenchymal nodules seen through the level of the left upper lobe, bronchus showing bilateral nodular opacities. This is quite common presentation in sarcoidosis. The other parenchymal lesions are reticulation seen in up to nearly 50% of the subjects, may form a very fine or very coarse networks. The linear infiltrates are common and may extend fan-wise from the hilum. Mottled opacities have a better prognosis than streaky opacities, is what Dr. Gupta had to say in his work on sarcoidosis. This is a 40-year-old male with reticulations, bilateral, both the lung fields. There's pleural thickening over there. Pleura is not very commonly involved in the sarcoidosis, but it can be involved also. This is seen in the left upper zone. Now, this is a very distinct pattern, the alveolar sarcoidosis, the acina pattern. It is present in up to 20% of the subjects. There is only one study that showed 20%, otherwise it is all between 10 to 12. May be discrete or coalescent, multifocal, bilateral, segmental consolidation, and you can see air bronchograms also. This can be frequently associated with radicular nodular pattern. I am going to highlight some of them. This is a patient with bilateral acina patterns, areas of consolidation with irregular borders, preferentially involving the central areas. You can see the CT showing you air bronchograms, which has been highlighted over there. And this is a patient after treatment, 11 years. But you can see that shadows have disappeared, but there is bilateral bullous areas, there is pleural thickening, and there is bronchiectasis and bulla also. So, in the end, the patient has deteriorated, although the shadows have disappeared. Now, this is alveolar sarcoidosis with subpleural nodules. This is a HRCT of a 30-year-old man through the level of the left upper lobe bronchus, showing an alveolar part on the left side. Also visible are subpleural nodules, which have been highlighted with arrows. Now, this is a patient who had acute alveolar sarcoidosis. He presented with hypoxemic respiratory failure. Till date, there are only 2 patients documented with such a presentation. This young man had gone to Vaishno Devi, and once he descended to Jammu, he suddenly had sudden progressive exertional dyspnea. When he reported to us, his saturation was 53 millimeter, his 53 millimeters of mercury. The chest radiograph showed alveolar pattern, and when we did a biopsy, bronchial biopsy, we found non-caseating granulomas. We initiated the patient on steroids, and there was remarkable and rapid improvement. Now, this is a patient who reported to us, and here you can see alveolar pattern over there, both the lung fields, and this is 6 months after treatment. This is the HRCT thorax. The mediastinal windows showed subcarinal bilateral hilar lymphadenopathy. The lung windows showed confluent alveolar opacities and areas of consolidation. Now, this is the classical bleeding that can be seen in sarcoidosis over here. This is along the perihilar lymph nodes. This is the bronchovascular bleeding bundles. Its perihilar concentration of fibrosis and lobar distribution is caused by the presence of granulomas along this along the bronchovascular bundles. On the left side, this patient has cystic spaces and fibrosis in contrast to the right side. Now, this is a patient with both ground glass opacity as well as honeycombing. HRCT through the right upper lobe shows an air bronchogram, ground glass opacities, and shows honeycombing on the right side. Now, this is one of the rare sarcoid galaxy sign, because sarcoid galaxy sign is caused by accumulation of the granulomas. It is encircled, and it is dense in the middle because there are more granulomas in the middle, and as you go towards the periphery, the granulomas are less, and that is why you have this variegated appearance, and you could even confuse it with the sunray appearance over there. And as I mentioned, it's pathological due to coalitions of the granulomas. This is another sign that has been described as sarcoid cluster signs. Here the granulomas do not coalesce. They are rounded long clusters of many small nodules that are close to each other but not confluent. Now, this is a very rare sign, the reversed halo sign. This is of course very well described in COP. It's a focal rounded ground glass bordered by a complete ring of consolidation. The ring of micronodules are surrounded centrally by ground glass opacities. Now, we have all done bronchoscopies, and we have all recognized these projections into the bronchial lumen, often described like wart-like excretion. They are white in color, they are bleb-like elevations. These patients can be asymptomatic, but they can manifest with cough, wheezing, and hemoptysis. This is endobronchial sarcoidosis. The nodular elevations are 2 to 3 millimeters. It's 40% of patients with stage 1 you can see endobronchial sarcoidosis, but in stage 2 and 3 it goes up to 70%. Narrowing of the bronchi can cause atelectasis, infection distal to obstruction. Now, the role of transbronchial ultrasound is now rapidly coming into focus. EVIS guided transbronchial needle aspirations are accurate, minimally invasive techniques. This technique has now spread all over, and there are many centers that are doing endobronchial ultrasound. And I think this is one of the most common indications of sarcoidosis, is the most common indications of doing a EVIS. The diagnostic accuracy is EVIS NA goes up to 84%. If you do a TB-LB, it's 43.9%, and a conventional TB-NA it goes up to 76%. So, you can see the diagnostic yield of EVIS TB-NA is higher for stage 1 and 2 sarcoidosis. Now, pleura is very rarely involved. When we were students, we were taught that if the pleura is involved, this is not sarcoidosis, but this is not true any longer. It doesn't hold at all. There's clinical significant manifestation of pleural involvement in 2 to 4% of the subjects. You can get pneumothorax, you can get pleural thickening, hydropneumothorax, trapped lung, hemothorax, and chylothorax. In other words, you can get the entire gamut of pleural involvement. The prevalence is thought to be less than 3%. For some reason, more common on the right side than the left side, and bilaterally it can occur in 22% of the subjects. Dr. Gupta pointed out that 6.6% of the patients in India had pleural involvement. This can be exudative or even transudative. Diagnosis is established on pleural biopsy with demonstration of non-caseating granulomas. Majority resolved spontaneously in 1 to 3 months, or with treatment when you treat patients of sarcoidosis. This is a 35-year-old man with non-resolving pleural effusion. He had mercilessly been treated for tuberculosis. He had even received second-line antituberculous therapy, but eventually when we had a look at him, we found he had a skin lesion. We did a biopsy, and there was non-case-eating granulomas, and when he responded well to treatment for sarcoidosis. This is the granuloma we took out from his lungs. Spontaneous pneumothorax is rare. Mostly you would find it if there is a transbronchial biopsy done and you are the cause of iatrogenic pneumothorax. But this is a patient who presented with pneumothorax. She was a 45-year-old lady with sarcoidosis along with bilateral prominence and reticular opacity in the lower zone. Now, sarcoidosis, as I said, is a multisystemic disorder. It's peripheral lymphadenopathy is more common in India. But erythema nodosum is far more common in the Western world, especially in the Scandinavian regions, than in India. And you can see that apart from one study that was from PGI, where they showed erythema nodosum in 20%, the variation is between 1.5 to 3%. Other skin lesions are reported up to 42%. Ocular lesions have now been recognized quite frequently, and in fact now ophthalmologists have been started referring patients to the pulmonologist. Arthralgia can also occur in patients of sarcoidosis. Now this is a lady, you can see the lesions over there, skin lesions on her feet and on her legs and even on her cheek. And in fact she responded only with methotrexate. This is another patient with skin lesions. You can see the reddish blebs over there. Now, hepatomegaly has been reported more frequently in India than in the West. Clubbing also, you can see 3 to 12%, cardiac involvement up to 12%, neurological involvement 13%, and parotid gland involvement in 15% subjects. In India, sarcoidosis is infrequently recognized and often mistaken for tuberculosis. And I'm going to highlight why this occurs by presenting to three or four cases. There is a diagnostic dilemma with tuberculosis because there is a remarkable similarity to tuberculosis. In clinical picture is same, the radiological picture is same, the histopathology, both are granulomatous lung diseases. Immunologic pictures are also more or less the same. Serum AS can be elevated in both the diseases. In India, the presence of miliaris lesions is almost always presumed to be tuberculosis until proved otherwise. This is a patient of miliary sarcoidosis over here, a 40-year-old man. And this patient had been treated for tuberculosis before he presented to us. You can see the same patient, bilateral extensive ground glass opacities were present also. We did a biopsy, we got a non-case-eating granuloma, and we started treatment for sarcoidosis. Now, this is a 65-year-old lady with cavitation. She had a acinar pattern or the alveolar pattern in both the right lower lung seats. There was bilateral hyaluroadenopathy. When we had a look at the CT, we found that there's typical bleeding over there and a well-defined cavitary lesions. Because of this cavity lesions, she was treated for tuberculosis. Nearly 2 years after commencement of therapy for sarcoidosis, the patient had hemoptysis, and when we got a CT done, lo and behold, we found an aspergilloma within the cavity. This is the first panel on the left is CT in the supine position, showing a fungal ball within the cavity, and in the prone position you can see there is a positional change of the fungal ball. So, cavitary alveolar sarcoidosis have been documented in 14 patients, complicated by an aspergilloma in 2 patients, and both these patients have been presented by us from Patel chest. This is a mediastinal window before presentation, bilateral hilar lymphadenopathy with bilateral perihilar consolidation. Lung window on presentation, you can see bilateral cavitation with the aspergilloma in the left upper lobe. You can see it over there distinctly, the aspergilloma is present over there. Now, the third presentation is tuberculosis and sarcoidosis occurring in the same patient. The sporadic reports of both the diseases occurring either concomitantly or sarcoidosis followed by tuberculosis or tuberculosis followed by sarcoidosis. Now, this entity was first proposed by Professor Scadding in 1962, and Dr. Shah from Bombay has said this is caused due to weakened tuberculosis pathogenicity and altered immune defense mechanism in select individuals, resulting in non-case-eating granulomatous sarcoidosis instead of the usual case-eating granulomatous tuberculosis. This is the state of transition through which tuberculosis demerges and evolves as sarcoidosis. And now let me just highlight the similarities between both the diseases. Both are chronic multisystemic diseases, affect the lungs, lymph nodes, skin, eyes and liver, spleen, brain, musculoskeletal system. Both can have acute presentations, as I showed you in a patient of sarcoidosis. Both are characterized by granulomatous formation. In fact, this is the hallmark of both the diseases. Both present, at least in India, there's a lot of constitutional constellation of symptoms. There's a lot of constitutional symptoms like fever, weight loss, anorexia, malaise, weakness and chronic cough. The differences remain that in sarcoidosis there's remission and exacerbations. Tuberculosis is a progressive disease. The pleura is very rarely involved in sarcoidosis, but very commonly involved in tuberculosis. The tuberculin test is allergic in sarcoidosis, but is positive in tuberculosis. The granulomas are mostly non-case eating, rarely case eating, but mostly non-case eating in sarcoidosis, but is caseating in tuberculosis. The serum AS levels are elevated in sarcoidosis and can be raised also in tuberculosis. Treatment for sarcoidosis is corticosteroids, and for tuberculosis is ATT. But if the patient was misdiagnosed as sarcoidosis when he has tuberculosis and you give corticosteroids, the disease is going to flare up. So the difficulties in treatment is risk of precipitating of tuberculosis following corticosteroid therapy for sarcoidosis when the diagnosis is wrong. Occasionally, a patient misdiagnosed with sarcoidosis may later develop tuberculosis, and this is attributed to the delay in diagnosis rather than the steroid therapy. Now, this is the suggested clinical approach to a patient. You have a look at the clinical picture. Of course, the imaging is very important, and after that you do the physiology, you do a complete PFT, 6-minute walk test, and after that when you are somewhere near the diagnosis, you do a biopsy. So you have a granuloma on biopsy, and granulomas can be caused by many things, so exclude other causes. If sarcoidosis is highly likely, get a skin eye evaluation, USG of the abdomen, and echo with mean PAP. And if you have a patient diagnosed as sarcoidosis, then you can also assess the quality of life. This is there's a specific instrument for measuring quality of life in sarcoidosis, and that will help you to take a treatment decision also. So what are the issues in India? The patient factors are reluctance to accept the diagnosis of sarcoidosis. There's plenty of doctor shopping going on from one hospital to another. And since the diagnosis is based on an invasive procedure, patients are very reluctant, and on top of that there are many people who start steroids on their own. Maybe the chemist will also start it for them. As far as physician factors occur, there was lack of awareness, which is now thankfully reduced, but there's still difficulty to recognize sarcoidosis. And one of the main reasons is there's a lack of easy standardized diagnostic criteria. Suppose you have tuberculosis, you have a sputum positive, or you have Mycobacterium tuberculosis cultured, you can say this is a patient of sarcoidosis, with tuberculosis. But in a patient of sarcoidosis, you do not have a single test to say that this is sarcoidosis. So, and on top of that, there's a lack of standardized treatment protocol, and we are of course surrounded and overwhelmed by the presence of tuberculosis. So sarcoidosis in India, in contrast to world data, is more often seen in males, generally occurs after 40 years of age, and usually of the chronic relapsing fibrotic type. So instead of answering question, I'll leave you a very perplexing question. What instigates granuloma formation? Could sarcoidosis be an infectious disease? There are many reports that when sarcoidosis increases, there's a decline in tuberculosis. What is the significance of mycobacterial DNA in granulomas? Could sarcoidosis be a caused by unidentified mycobacteria with lower virulence? Cell wall deficient mycobacteria maybe? Is sarcoidosis an altered response to mycobacteria modified by the gene-environment interaction? So there are many questions we still need to answer about this very complex disease. In fact, if you ask me, I would like to use the words of Sir Winston Churchill to say, it's a riddle wrapped in a mystery inside an enigma. Thank you very much indeed.